Hello, my name's Caroline. I'm one of the audiologists at NHS Tayside, and I've been asked just to give you a kind of brief overview and flying visit of audiology. So, I want to go over some of our diagnostic assessments as well as some of the rehabilitation options that we've got. If you look at our service as a whole, we have things like diagnostic hearing assessment and rehabilitation in adults, so pure tone audiometry, speech, tympanometry, acoustic reflexes, OEs are probably our most common. We've got vestibular assessment and rehabilitation, so computerised dynamic posturography, VEMPs, VHITs, VNG calorics. We also have counselling options for patients, so there's tinnitus counselling, we have hearing therapy, and we also have special adult rehabilitation for some more advanced technology and assistive devices to help out patients. We have an implantable devices service which offers assessment and fitting. This is for bone conduction devices or middle ear implants. We don't do it for cochlear implants, although we provide the assessment and some speech assessment and audiometry assessment for the Cochlear Implant Centre. But all the cochlear implants are done at a national centre in Kilmarnock in Scotland. We've got paediatric diagnostic assessment, so we start testing our hearing from birth, so the newborn hearing screening programme, the ABRs, OEs, visual reinforcement audiometry and play audiometry. Our basic go-to assessment is obviously pure tone audiometry. We present a pure tone to the patient, they press a button on the hole and let us know if they hear it, and then we plot the results. We work in soundproof rooms, and we work with audiometers which are calibrated to measure ear conduction and bone conduction thresholds. We measure ear conduction thresholds from about 125 to about 8,000 kilohertz. This is because we want to get the sounds in speech. That's kind of our main focus. We can test beyond that in certain situations, but on the whole, we're focused on what sounds the patient can hear speech-wise, and if a hearing aid will help them. Bone conduction thresholds can be recorded between about 250 and 4,000 hertz. BSA, our governing body at the moment, says we only have to measure up to about 2k. On the whole, we will still test between 3 and 4 as well. Maximum ear conduction thresholds we probably measure up to about 120. Bone conduction can measure up to about 70 calibrated wise. We're probably only going to go to about 60 because above that it produces quite a lot of distortion. The audiogram you're probably all quite familiar with. On the left is your basic audiogram, so we go from really quite quiet sounds all the way up to quite loud ones, and along the bottom is pitch, so the low pitch bassy ones up to the high pitch squealy ones. Technical. Normal hearing for us is classed at about 20 dB. So if the entire audiogram is plotted above this line, obviously from a hearing aid point of view, we're pretty happy. They're hearing all their sounds and speech, so they're getting what they need. The graph on the right, the audiogram on the right, shows one of our counselling software, so it plots some of the information. So again, a high frequency sound is probably a bird singing, a loud sound, baby crying, and a jet engine taking off. This classes the hearing levels as normal, mild, moderate, moderate to severe, and severe to profound. We generally miss out the moderate to severe version, so we would have normal hearing, which would be 20 and above. We would have mild hearing losses about 20 to 40, a moderate 40 to 70, a severe 70 to 95 usually, and then a profound would be 95 and above. We describe the audios from the type and nature of the hearing loss, so a bilateral mild to moderate high frequency sensory neural hearing loss. We don't describe it in percentages. If there's a large asymmetry shown up in audiometry, we will mask the ears. Basically, this is because the head is only so big, so if there's a large asymmetry, the better ear will eventually pick up the sound if it's played loud enough. So we play a white noise into that better ear just to distract it. The rules of masking are, so we've got rule 1, which is related to ear conduction. So basically it's masking is needed at the frequency where there's a difference between the left and right, not masked AC thresholds, of 40 dB or more. This is with using headphones, and if we use insert earphones, it's 55 dB or more. Just gives us a little bit more leeway. Rule 2 is bone conduction. So it's where masking is needed at any frequency where the not masked BC threshold is better than the AC threshold of the either ear by 10 dB or more. The worst ear by ear conduction would be the test ear, and the better ear would be the non-test ear in this case. On a note to that, the BC can never be below the AC threshold. So if you're getting audiograms shown to you or given to you where the bone conduction threshold is below the ear conduction threshold, you probably want to get them checked or double checked. We would usually watch our bone conduction placement for that, or maybe re-instruct the patient. Sometimes it does show up, but on the whole, if you're getting consistent responses where the bone conduction is below the ear conduction, something is going wrong with the testing procedure. Rule 3 is kind of a caveat catch-up rule. It's involved with ear conduction, but it's where Rule 1 hasn't been carried out. So on the whole, Rule 1 will pick up most of these points, but if there's a bilateral conductive, sometimes we need Rule 3. And it's basically masking will be needed additionally where Rule 1 has not been applied, but there's a BC threshold in one ear is more acute by 40 dB with headphones or 55 dB with inserts than the not masked AC threshold attributed to the other ear. I know you guys don't need to know this overall, but just to give you a background of what masking is. On the audiogram, the symbols always stay the same. So we've got unmasked symbols are a circle for the right ear and a cross for the left ear. Right is never wrong. The bone conduction is always a triangle. In audiology, red is always right and blue is always left. It stays the same throughout everything. When masking is carried out, what we do to show that we've carried out masking is we change the symbol slightly. So basically, if the frequency and point moves, we will colour in the old point in its entirety, like in the first symbol there, just to show that we've carried out masking and that the point is moved. There'll be a new unshaded point plotted on the audiogram. If we carry out masking and the point stays the same, what happens is we'll colour in half the symbol, just to show again that it has stayed the same, but we have carried out masking on it. The bone conduction thresholds change completely when masking has been performed, so they'll change into the bracket, and what will happen is it will show you side-specific information. So depending on what way the bracket is pointing and what colour it is, you'll get the mass thresholds of the bone conduction. Then just to give you a few examples of some audiograms, we've got 3 different variations. So basically your top left here, you've got a sensorineural hearing loss. So a bilateral, mild to profound sensorineural hearing loss, bone conduction thresholds sitting nicer on top of ear conduction thresholds. If we go to this one on the right hand side, a moderate to mild conductive hearing loss. This is a true conductive hearing loss just because all of the masked bone conduction points are above 20. As soon as one of the masked bone conduction points drops below 20, it changes to a mixed hearing loss. So the one in the bottom left here is a mixed hearing loss. So it's a bilateral mild to profound mixed hearing loss. You have some conductive components, you've got quite a lot of conductive components, especially on that left side, but they're below the 20 dB within normal limits. So we would call that a mix with a large conductive component. And I feel that we should give a quick mention to hearing aids. So depending on the pure tone audiometry results, tells us what suitability the patient's got for a hearing aid. Most patients these days get the hearing aid in the top right here, which is the open fit style of hearing aid. So it's a little bit that sits behind your ear and a little wire, plastic tubing that sits in your ear canal. We still do the mold fit. Generally it's for more profound hearing losses or those who require just a superpower hearing aid. Kids also have a lot of the mold fits just because it's easier to get in young kids and to make sure it stays in. They can get fun designs. Our hearing aids are gone from being the NHS beige things, bananas. We now have a lot of technology enabled apps and things like that that control our hearing aids. They can connect to your iWatch, your iPhone, you can turn them up and down, you can geotag certain situations. So if you're in work, it automatically changes the hearing aid to set to one program. As soon as you leave work, it will set it back to the other program that you like. They would have Find My Hearing Aids, so if you lose them, you can press a button in the app again. It'll hopefully show you where they are. We've got a lot of assistive devices. Some examples on the right hand side there, just it'll connect to the TV, it'll connect to a phone. There's a multi-mic which will sit in the middle of a desk for presentations, or it can hook on to the presenter. There are other options available from technology now, not just a beige banana. The second most common test in audiometry is probably speech audiometry. We're going to talk a little bit about AB word lists, but it can also include BKB sentences, speech and noise testing such as Quicksin, BKB and noise, AB word lists and noise actually is also included. These can be quite good either in the sound field to see how the patient is getting on with their hearing aids or their implantable device, or we test them with headphones on and see how they respond. Basically, we get them to repeat back the words or part of the words. And once we've played it, the aim is that they get 100% and that it drops down to 0. So there are 15 lists, each contain 10 CVC words, and with 30 phonemes in total. So we calculate their speech recognition threshold by where 50% of the words has been achieved. This should tie in with our pure tone audiometry if we're doing it with the headphones on. Generally, it should tie in with a pure tone average of the audiometry, which is generally the average of 5, 1 and 2. So this can give us a little bit more information about how the patient is processing sounds, or can sometimes highlight us if the patient has been a little bit non-organic. So the first results I'm going to show you is AB word lists with headphones on. This is showing an SRT of 15 decibels on the right, red is always right, and 14 decibels on the left. So both ears are around about the same, 15 decibels and 14 decibels. If we tie that into the pure tone average of an audiogram, would be within normal limits. So this speech audiogram is indicative of normal hearing thresholds bilaterally. The second one, again, is AB word lists given over headphones. So your SRT is 32 decibels on the left and the SRT is 15 decibels on the right. So there's obviously an asymmetry between these ears. On the right it would be within normal limits, but on the left it's looking like there's maybe a mild to moderate hearing loss. We can assume that it is a conductive hearing loss because the entire graph is shifted to the right. So basically if we make the sound loud enough, it'll bypass any problems between the middle ear and get to the inner ear. We just have to make the sound loud enough. In this case, it doesn't have to be too loud, so it's probably not a massive conductive loss because at 60 decibels, they're getting all the word. But through headphones, that can be perceived as quite loud overall. So yeah, so this would be indicative of normal hearing thresholds on the right and a conductive hearing loss on the left. And the third one, again, is AB word lists with headphones on. So basically, again, the right ear is looking quite good, the SRT of 15 decibels. The left ear is showing a little bit of a strange result. So basically, the SRT is quite high, so it's about 45 decibels, so kind of a moderate hearing loss. And it's got this rollover. So the rollover is indicative of retrocochlear pathology. Basically, if the sound is getting louder, the discrimination of the sound is getting worse. So previously, if there was a massive asymmetry and we did speech tests, this was the result that showed up, we would then refer for an MRI scan. But obviously we just miss out that stage now for MRI. We would just, if they get a large asymmetry in their pure tone audiometry, we would refer them over for an MRI scan. But on the skull-based clinics and stuff, we usually do speech just to check how their speech discrimination is going. So yeah, this is indicative of normal hearing thresholds on the right and a retrocochlear loss on the left. Tympanometry should be a familiar one to you all. So along the top is an A, a B and a C, and in the bottom is an AS and an AD. Basically they're Jaeger types. In audiology we don't really describe them as Jaeger types anymore. We would just say peak, flat or negative, so you may get it described either way. Peak type A is obviously nice and normal. Type B can be middle ear fluids, or it can be a massive perforation depending on your canal volume. Negative can be resolving eustachian tube. An ES can be a sign of otosclerosis or fixation, and AD can be hypermobile TM or a circular discontinuity. If I show you a print off of one of our test results, it's actually quite a nice normal one. So we've got an ear canal volume of 0.8, nice and within normal limits, a pressure of 25 dAPA and a 1 mil compliance. So yeah, a nice, perfect Tympé really. Acoustic reflexes usually go hand in hand with tympanometry, although we don't use them that much anymore. There are other ways we can get some of the results that we're after. So basically the acoustic reflex is the lowest intensity of an acoustic stimulus that elicits an acoustic reflex results, which is a contraction of that stapedius muscle. A change or deflection of 0.03, or in some cases 0.02, is usually taken as a minimum change required to confirm the presence of a reflex. It sometimes depends what machine and depends what normative values you're using. So if you look at the results at the bottom here, we have a 0.11 at 95, which is quite a big deflection, which is a massive result. And what happens is when we drop it back down, it goes to 0.04, which is still quite a big response overall, but it's the minimum level that it's required to elicit the result. So by 85 it disappears to 0.01, so we would take 90 decibels here as the acoustic reflex. You have to be aware that 5% of the population don't have any acoustic reflexes, and acoustic reflexes in patients with normal hearing are about 70 to 80 decibels louder than their pure tone threshold. So it can again sometimes give us some information if a person and a patient is being a little bit non-organic. We can test if they've got a nice acoustic reflex at about 80 or 90 decibels. It would imply that their pure tone thresholds are about 10 dB. So if they're presenting with a 60 dB hearing loss, we know that something's not tying in across the board. There are loads of testing contraindications to acoustic reflexes, including tinnitus, hyperacusis, and severe recruitment. Obviously, it's some really loud sounds played in the ear, so you don't want to do that if it's going to upset or increase anyone's tinnitus. The outer hair cells are mechanically motile and constantly in action. This work often produces a sound, which is known as an autoacoustic emission, so an OE. So we'll test for this. This means obviously that the normal cochlea not only receives sound, but it produces sound. Transient autoacoustic emissions can be picked up in about 98% of the time if they're present with some of the software that we have. The purpose of OE testing is to determine the hair cell and cochlear status of the ears. It's an objective test and it'll look at a specific frequency range, generally the mid to high frequencies. Research has shown that the correlation specifically concerns the outer hair cells, and although they are not themselves activate any primary auditory nerve fibres, there is a strong correlation between the absence of OEs and a hearing loss. So we've got a few different variations of evoked OEs. So we've got transient OEs, which are probably the most common that we use, and actually is the one in the picture here. So that will result from a short duration stimuli, such as a click or a tone burst, and we measure the sound coming back. You've got distortion product OEs, which are emitted in response to two simultaneous tones at different frequencies. And then you've got sustained frequency OEs, which, as the name suggests, is a sustained tone, which we're measuring the sound back. They're small, so usually only less than 30 dB SPL. And they arrive in the external auditory meatus due to the middle ear receiving the vibrations from within the cochlea. So if there's problems with the middle ear, this can attenuate that symbol. So if they've got a conductive hearing loss or they've got otitis media, all these kind of things can throw off an OE, and you won't get any present. It's quite interesting for telling us, again, how the cochlear function is coping. And if a patient presents with a profound hearing loss, and we do an OE and they've got OEs, it's usually quite unusual, because anything beyond a mild hearing loss, your OEs disappear, but anything below that, they'll usually be present. So again, we're looking for non-organic type cases. We'll do a double check with an OE just to see what's happening. Obviously, babies get OEs as part of their newborn hearing screening assessment, generally just a screening OEs, but we can use it in both situations. If we look at one of our test result screens, again, this is a transient evoked OE. On the left is your left ear, and on the right is your right ear. This is the signal going in, and this is the response waveform. On the left side, the response waveform doesn't look very big, and on the right side, again, you've got the signal going in, the response waveform is increased on that right side. If we break it down from here, this is your background noise. We don't get any signal above background noise on the left ear, and on the right ear, we're getting quite a lot of signal over the background noise. Not on all frequencies, but as long as we've got it in 2 or 3 adjacent frequencies, we're pretty happy, and that's a nice pass. So we've got pass on the right ear, and we want to retest this left ear and get some more information. Okay, so if we go into some of the other rehabilitative options for patients, bone conductive devices are a good option for patients who can't really wear conventional hearing aids. Whether that's because they've got a massive conductive component in their hearing, so when we're trying to give them all that power through a hearing aid, it's distorting and they're not getting the full clarity of the sound, or whether it's they're unable to wear conventional hearing aids. Again, if they've got a large conductive component, wet perforations, wet mastoid cavities, and we're putting moulds in there, it's sometimes not the best for them. Bone conducting devices are an option for single-sided deafness patients. They can be fitted to an abutment. It's probably the most common for the bone conduction devices overall. There's a little adhesive. Medel produce an ad here which sticks to a little sticker that sits on a mastoid. Cochlear do them where they'll sit on a magnet, or we can have them on a soft band. The soft band obviously comes in handy for testing more in adults. The adults can take the processor and trial it and use it in a soft band. For paediatric patients, obviously the soft band comes in really handy for babies and things like that, pre-surgery options. The soft band will attenuate some of the sound, so you won't get that full gain range, but it'll give the patients an idea of what to expect. So from a bone conduction point of view, this is two of the major manufacturers, so the Cochlear range and the Oticon range. Again, these will be the abutments. Cochlear have them where you can connect them to a magnet. Both have options for a soft band. So the Cochlear range at the top, this is our generic processor. Again, about 45 dB bone conduction threshold would be the max. They have a power processor, which is about 55 decibels, and a super power processor, which is 65 decibels. Oticon follows the same idea and the same decibel level for all their processor recommendations and fitting ranges. We found it can be quite patient dependent if we can get up to 65 decibels on a power aid just from the fitting point of view. So we usually like to leave some headroom for patients overall. Oticon also have an Oticon 4, which doesn't come with the power or the super power options, but it's quite a neat little processor that is really technologically enabled. They all are in fact quite highly driven by technology. Again, they'll connect to your phone, they'll do other things that the hearing aids can do. You can adjust them via your phone, you can geotag, they'll attach to assistive devices, we can connect them directly to the TV. There are loads of options for these, so they are kind of nice little processors that give a lot of information. Medel have their variation to the bone conduction device on a soft band. It's the Medel ad here. So the ad here works by, there's a little adhesive adapter that sits behind the ear, and the processor just clips onto it basically and passes the sound through that way. It's not got much power and it's not got much adaptive features, so it works really well for true conductive hearing losses. So where your bone conduction thresholds are all within normal limits. Same for single-sided deafness. It works really well for single-sided deafness as long as the good ear, all the thresholds are within normal limits. It can be used across age group. We've tried them on paediatric patients all the way up to adult patients. Seems to be a little bit more successful so far on the adult patients than the ones that we've tried, but it's a little bit less invasive for paediatric patients than a soft band that sits across the skull. Medel's version of a bone conduction device on an abutment, their variation on this is the vibrant bone bridge. So you've got the implant that sits fully under the skin and the processor sticks on top via a magnet. You have to have bone conduction thresholds probably about 45 dB, so it's not got the same power as those power processor BAHAs or the super power BAHAs, but there'll still be a variation, and patients tend to like them just because you don't have the abutment. Medel also offer another variation, which is the vibrant sound bridge middle ear implant. This can work with conductive hearing losses or sensory neural hearing losses, so gives some more options for those patients who can't wear conventional hearing aids for whatever reason. The floating mass transducer connects to the short or long process of the incus or the stapes foot plate. This will help with localization of sound, and also it gives a little bit more of sound side specificity, so patients can hear a little bit more on that selected side, and are more likely to know that the sound is coming from that side, whereas sometimes with the bone conduction devices they don't get that true localization of sound. They just get the sound because it always goes to the better ear either way. So ABR, or auditory brainstem response audiometry, is not really a true test of hearing, but it'll help estimate the degree of hearing loss by finding the lowest intensity level where wave 5 is present and repeatable. We are kind of really only interested in wave 5. The latency information though, and the results from bone conduction stimuli can help provide insight into the nature of the hearing loss. The ABR is part of the diagnostic assessment in newborn hearing screening, generally when they're really young, so they'll sleep through the test and be nice and still. So like the example of this little guy all kind of wired up. This is the results from one of the babies. Wave 5 is at 8.92 and 9.28, a little bit further down. The waves are clearly repeatable. This is about 35 and this is about 25, so within normal limits. So this baby passes its diagnostic screen with hearing levels is estimated within normal limits. The table on the left shows a little bit more information for growth. So as the child grows, the wave 5 latency tends to change. So we have a whole bunch of normative results which we will report and compare to when we're doing the testing. This slide's obviously just to show you the waveforms that we're after and the structures that they're associated with. And again, the waveforms and the amplitudes and the average amplitude and the latency and the average latencies that we would compare our ABR results to. So as mentioned, the ABR is usually performed as part of our newborn hearing screening. So the babies are usually tiny, a couple of weeks old. They'll sleep through the process once they're wired up. When they get a little bit older, a little bit harder for them to sleep or to not fidget when they're moving and get muscle and artifact tracings. This can be the same for adults. They can tend not to sit still. They don't necessarily sleep through the procedure, so we can sometimes change it. So we'll do cortical evoked response audiometry on them. Same idea, it just means that they can sit and read or they can watch something. Just as long as they're relatively still, we can do the same idea and get thresholds. So this is just a comparison table, which is quite good on when we would maybe do an ABR versus a cortical and what information it can give us. The cortical can be quite good to present and pinpoint the audiogram overall. For adults, it's really quite good. So on the same machine that would perform the ABR and the CERA, we can also perform a VEMP, a vestibular evoked myogenic potential. So this is more for vestibular assessment. On the left here, we've got a CVEMP set up, and on the right, this man's set up for everything. He's got a little bit of a CVEMP set up, and he's got an ocular VEMP set up. So to understand the difference between the CVEMP and the OVEMP, the CVEMP tests the sacral inferior nerve. It's recorded from the SCM muscle, and it's an inhibitory potential and an ipsilateral response. So we play a loud tone in this case in the right side, and we're measuring the right side. When the muscle is flexed, there's a split second when that flex releases, and the waveform is easily produced and visualised at that point. The OVEMP is primarily a utricle and superior nerve response. As part of the OVEMP response comes from the sacral, there's an excitatory response which will record from the extraocular muscle. So he's got everything kind of wired underneath his eyes. This again generates a waveform when the person's looking up. It's a contralateral response, so it'll be on the opposite side. And also it can be quite hard to get the patient just to look up and not tilt their head back when performing the OVEMP. So the VEMPs can give us loads of information. We use it a lot for suspected semicircular canal dehiscence. They're using it more for migraine. It is kind of seeing how the otoliths function overall. It's given us a lot more information for vestibular assessment. It can disappear a little bit with age though. So if you're nice and young, generally there's a nice clear waveform. 75-year-olds, suddenly we don't get nice recordings. So it is a variable dependent on age. And then in this slide we've got the results of one of our VEMP assessments on a patient. On the left here is blue and the right is red. Again, audiology, right is red, blue's left, all across the board. These are average waveforms, so although this looks like a nice single waveform, it is multiple waveforms averaged. On the left, we're getting a nice response at 100 decibels, 90 decibels. Yeah, there could be that looks to mirror it on 80, and then it kind of disappears. So that's a nice normal VEMP waveform on that side. This one on the right side, 110, really clear, 90, 80, it actually only disappears at about 60 decibels. So the VEMP response is coming in a lot quieter, and it's more of an increased response when it is coming in because the amplitude's really big compared to the amplitude on the left. This is an indication of semicircular canal dehiscence on this side. So the other test we could do is sometimes we do VNG and put goggles on and film their eyes when they're hearing some loud sounds. A CT scan will also help to see the semicircular canal dehiscence. So another popular vestibular assessment is computerised dynamic posturography, particularly the sensory organisation test. So the sensory organisation test is on the right here and someone standing on the balance platform on the left. The SOT is an assessment of postural control. It provides a relative measure of the patient's ability to utilise sensory input from vision, vestibular and proprioceptive inputs to maintain upright and facing forward. It doesn't give us any sight of lesion information, it's more just an assessment of functional ability, but it does give us a lot of information. So we do 6 different conditions. The first one is kind of eyes open, facing forward. We then make it progressively harder. They stand with their eyes closed, the surrounds move, the foot plate moves with their eyes open and eyes closed, or their eyes are open and everything moves. And then the computer can see what's happening overall. Generally, if they're having issues with their eyes shut and the foot plate and things are moving, it's indicating more of a vestibular hyperfunction. This results, obviously this patient did quite well at the start and then progressively went downhill. The sensory analysis shows that they're not doing very well overall, but particularly the vestibular system. They're not showing any input to stay upright by using the vestibular system. They've got a really good centre of gravity though, which is given quite a fair amount of stability. So what would happen here is we would do this prior to carrying out some vestibular rehab, and then maybe in 3 months' time or 6 months' time, when they've done a full course of vestibular rehab, we would do it again and see if there's any improvements. Also, we can use it as a slight screening tool, so we'll do this, carry out the test, actually showing a vestibular weakness, so then we'll go get some more information from calorics or VHIT. VHIT assessment is basically just a computerised version of your bedside Hamagi head thrust. I just do it with computers overall. There was a pair of goggles with an infrared camera. We get the patient to look at a spot on the wall, and then we tilt their head from side to side. It shows overt and covert catch-up saccades, and it shows them quite nice and clearly. You can see them following the route over here. This one is a lateral canal, nice and within normal limits, looking good. There's a few eye movements when we shake the head, but nothing major or consistent. They're kind of all over the place. I don't know how clearly you can see this one, but on the left side there's some really overt saccades and catch-ups that are consistent and in the same path every single time on this left side, so it's not within normal limits. On the right side it looks pretty good, and this is showing overall the blue is within abnormal limits and the red is within normal limits. It's maybe a little bit easier to see those repeatable waveforms when it's done in 3D, so again it causes a channel. We can see the same point every time that catch-up saccade's happening, and it gives us loads of information from that point of view. This patient's not doing very well on either side, indicating there's a bilateral hypofunction overall. Both eyes are trying to catch up all the time. The VHIT can give us a lot of information on the site of lesion, and it's a quick test to perform. It doesn't necessarily take away from calorics, but it's quite good if you do calorics and VHIT together, just to give a full indication of what's happening overall with the vestibular pathway. This is a caloric result from an ear caloric. So at the top here we've got the irrigation responses. If we're looking at these, we're looking at them to be nice and a mirror image of each other, which in this case they pretty much are. But you'll see this is an nystagmus plotted. You'll see on one side there's quite a strong nystagmus, and on the other side there's not as strong a nystagmus overall. If we look at the phrase diagram again, there's a little bit of a weakness overall. You can see this is a nystagmus plotted. See, look at the nice clear nystagmus on this side. It's still there on this side, but it's just not as fast. So this is showing a 42% weakness to the left side, and it indicates a left vestibular hyperfunction. But abnormal caloric results can be presented in loads of different ways. So again, you've got that asymmetry between the ears, which are shown here, which is a unilateral weakness, or a directional preponderance, which is just a numerical description of how the amount of right beaten nystagmus compares to the amount of left beaten nystagmus. It just shows us that as a number. And it can be symmetrical and really weak responses, which can indicate obviously a bilateral hypofunction. But again, the caloric result is usually quite good in the fact that it can be quite repeatable, and it gives us loads of information in quite a quick assessment. I kind of just want to fly through some paediatric audiology information with you. This is, again, most of it's been covered with the ABR and the OE, and they have the same hearing aids, they have the same assistive devices as the adults, so on the whole it's just a slightly different hearing assessment. The newborn hearing screening, as I say, obviously it's offered a screen within 28 days of birth. It can be an OE or a screening ABR depending on where the patient is located. There's a well baby pathway and a NICU baby pathway, so if the patient is well and they pass their newborn hearing screen, all is well. If they've been in NICU, we would probably quite like to do an ABR just to double check, or if they have any genetic history of hearing loss, we would do an ABR, a diagnostic ABR again, just to check. So from a hearing test point of view, the ABR would be the first one, and then at probably about 18 months they get visual reinforcement audiometry. So in this case, they're conditioned to hear a tone, and then when they hear the tone, they turn to the stimulus. So in this case, a dancing bananas in pajamas. So yeah, the child is conditioned quite well. We can get, if we put inserts in, we can actually get side-specific information from VRA. VRA obviously requires the baby to be able to sit up, to turn their head, and to be able to see the stimulus. So it's on developmental age rather than gestational age. Yeah, and it's really quite an effective test overall. When the child gets a little bit older, we move to play audiometry. Again, it's conditioned. We'll usually condition on a sound field. This is what's happening here. They're playing a tone. The child is picking up a coin and putting it in a piggy bank. And once they do that, that's a reward for hearing the tone. We can then put headphones on and again get site-specific information. This can be, in this case, it's a coin in a piggy bank. The actual generic way is usually the men in a boat. It doesn't really matter what the child does as long as they respond in some way that we can see that they're responding to that tone and that they're hearing that tone, and that's given a full condition play. And yeah, so that's a fly-in visit to paediatric audiology. There's a lot more about it than that, but again, they have the same bone conduction devices, they have the same ABR assessment, they have the same hearing aids and things like that kind of overall. So yeah, I've tried to give you a brief overview of audiology, some of our diagnostic